Thank you for joining us. So Don was handing out some materials. So if you don't have one of our little packets, please raise your hand and he'll bring one around to you. That's the packet. Yes, exactly. So glad you were able to join us today. Hopefully this will be an informative hour, and we'll have some information that we can share. We'll also leave some time at the end for some questions too. Actually, you can even raise your hand if you have a question. That way you don't have to hang on to it. That you can ask it right away and have it be a little bit more conversational. So let me first introduce myself. I'm going to then have Don introduce himself. So my name's Michael Banville, and I'm the director of the Long-Term Care Ombudsman Program for South Shore Elder Services. We are an area agency on aging that is based out of Braintree, Massachusetts. And you're probably saying, why is an agency based out of Braintree here in Walpole educating us about a long-term care ombudsman program? It seems like a bit of a far stretch. Well, 5 years ago, there was a consolidation that happened. So that in the past, HESCO had a long-term care ombudsman program. HESCO is also in Walpole. And there was a merger that happened, and HESCO decided to not continue to run the ombudsman program, and they gave it to us in South Shore. So we operate a double region of residences. We have 37 nursing homes that are in our purview. Actually, I stand corrected in that there's 34 nursing homes and 3 rest homes. No assisted living residences are part of our program, but there is an assisted living ombudsman program that I'll talk about in a little bit. So 37 homes under our purview. They go from Quincy and Milton all the way down Route 3 to about the Cohasset area. And then along Route 95 from Dedham all the way down Route 95 to Franklin. So those 2 stretches of highway are what make up our region. We have 29 ombudsmen. Don is one of the ombudsmen. I'm an ombudsman as well. We'll talk a little bit more about what is and what makes for an ombudsman, but I wanted to have a chance for Don to also introduce himself, and then I'll take the mic back after that. So.
Well, I'm a Walpole resident, and I retired a year ago next week. I did my training as an ombudsman last May and June, and I've been in a long-term care facility in Norwood since that time. It's licensed for 166 beds, spread over 4 units. 1 unit is a memory care unit, and a second unit is a rehab unit, which gets a fair amount of turnover. And I think that's it for the moment. We can continue.
So talk a little bit about kind of the history of the programs. You have an appreciation of the context of how this ombudsman program came up. During the presidency of Richard Nixon, there was a growing amount of concern with some of the quality of care and quality of life that was happening in nursing homes. It started in the nursing home environment. In Massachusetts, we also had what are commonly in the past referred to as level 4 rest homes. The concept of ombudsman also was applied to that form of residence too. And then more recently, as assisted living residences have emerged, within the last 30 years, the ombudsman program was expanded yet again and into that industry about 10, 15 years ago. An ombudsman, the Nixon administration said, we need a form of advocate for residents and for families when there are questions. And so that they designed this model at that point in time, like I said, 50 years ago, to try to respond to some quality of care and quality of life issues, some resident rights issues as well. We'll talk about those at the end of the presentation. and that there was a program model that was experimented with, and Massachusetts was one of the originators of this model. There were about 4 other states where an ombudsman program was created, and we were trying it out some 50 years ago. So we, in Massachusetts, were one of the founders of this concept of a resident advocate kind of a program. Some of you may be saying, this weird word of ombudsman, what is that? How did we land on that? Has anybody heard and also know the origin of the word ombudsman? Raise your hand if you do. No? Okay. It's a Swedish word, ombudsman. And what it literally translates to is the representative of the people in government. The representative of the people in government is what the translation of ombudsman is. In more common language, a resident advocate. There's ombudsman in all kinds of industries. The insurance industry has ombudsman. You name it, there's all kinds of ombudsmans. I'm blanking on other examples, but the point being is that there's somebody that you can turn to if you have questions about the quality of the service you receive, the care you receive, the quality of life. That's what an ombudsman does. The person listens, raises up the voice of the resident. This is often how we think about the work that we do, that we are trying to raise the concern, the voice of the resident to be able to deal with whatever that issue is that's going on inside the nursing home, the rest home, or the assisted living residence. Just want to make a kind of I'm doing this with my hands because I'm trying to express that we tend to work inside the footprint of the nursing home, that we're inside, not outside. So our advocacy is going to be taking place within the context and the care that's being provided within the 4 walls of the nursing home. That's kind of at this long-term care ombudsman program. That's how we think and how we function. It's our purview. So the ombudsman, if we're advocates, we go into a nursing home. Don will talk in a minute about how he does this. But we go in and we are primarily first engaging the resident. The resident is our client, so to speak. Notice my language. I refer to the person living in a nursing home as a resident, not as a patient, because in a nursing home or a rest home or an assisted living residence, that space that the person lives is their home. That's how we think about it. That's how the program thinks about it. If you're sharing a room with someone in a nursing home, your part of that room is your home. So we then think about the person that's living on that side as someone that has access to care, food, personal services, maybe rehab services, physical therapy, occupational therapy, all that. There's a lot of complexity. There's a lot of moving pieces that could be happening inside a nursing home. So when we go in as an ombudsman, we're listening and we're watching for all the different aspects of what could affect the quality of life for someone who's living there, for a resident who is living there in their own home. A nursing home has a variety of staff. An administrator, usually a director of nursing, a head of social work, often sometimes also referred to as the head of social services, an activities director, maybe a head of rehab if there's a rehab program, a facilities director, person who kind of oversees the operations and the physical plant of the place, food services and dining. There's a whole team. A nursing home is set up as an interdisciplinary If you think of each of those categories of people that I just put out there as disciplines, as parts of the larger whole that are caring for the residents. For us as an ombudsman, if we're going into the home and our focus is first and foremost the resident, we're listening for how is the resident also interacting with the different aspects of the nursing home, the different players, the different people, the different caregivers. But in our case, we are typically assigned a particular person. They're called in our world our contact person that we go to if we discover an issue and we receive consent from the resident to act on an issue, then we go to this contact person. Why have that? Because at its core, we are focused on what the resident needs and wants, and the resident does need to give us permission to be able to act on something. When the program was founded 50 years ago, this idea of resident privacy, confidentiality, resident self-determination was core to what it means to be an ombudsman. And what the government at the time felt needed to be built up was to have a sense of empowerment by residents that the resident would be able to either advocate for themselves, or if they felt that that wasn't going well and they needed somebody else to help them with that, that's where we kicked in. So that the government has set up this whole concept of an advocate that goes in to support the residents. There's an ombudsman program in all 50 states. So in our case, in Massachusetts, the main program lives inside the Executive Office of Health and Human Services in Boston. There's a state ombudsman. Her name is Carolyn. She's my boss. I'm the regional director. I report up to Carolyn. And there's an assistant, Susan. They run the entire state program. We have a state trainer, and then we also have a state data management person. That's at the highest level in Massachusetts. There are these key people that are overseeing hundreds of nursing homes across the state. We have 37 in our catchment, right? Each region in Massachusetts then it's carved up. There's 21 programs across the whole state. We have a double region. We're counted as one region, but we do have two sets of residences in our area. We have 29 ombudsmen, and I'm training 3 more to cover those 37 homes. Don is assigned currently to 1 home, and that's pretty much the case with all our team. I cover a couple, I'm the director. We have a couple of other people that they are covering a couple of residences for us. But pretty much for the most part, every ombudsman is assigned to 1 home. Why just 1? Because the expectation from the design of the program is that the ombudsman will go in roughly every week to meet with residents, to just roam around the residents. Don might have a short list. I might call Don because a message has come into the office with maybe a request for some support. And I'll say, hey, Don, I've got a situation, and add this person to your short list when the next time you go into the home. And see what the need is. See if there's something that the person is asking for our help with, if they give you consent, what is the nature of the situation. So our team goes out every week. People are going into homes across the whole state, and in our case, like I said, 37 homes. I don't want to steal Don's thunder because I want him to describe a little bit more of what he does when he actually goes through the door. But for now, just know that there is this concept, this program and concept of advocacy that is going into homes to try to help residents. Before I go any further, I'm going to have Don introduce a little bit more of what he does when he goes in, and then we'll go from there.
So as ombudsman, we make our own schedule. So that was one of the things that was important for me. I go on a day and a time that I've chosen for a variety of reasons. I generally go on a Monday morning because that way there I know I've done my duty, and if life gets in the way for the rest of the week, I know that this part of it's been taken care of. By the way, as the ombudsman, unlike Michael and some of the people at the DPH, we are all volunteers, so it's not a paid position. I thought what I'd do is two things. First, kind of walk you through a typical visit, and secondly, talk about some of the issues that I've had to deal with. So when I get to the nursing home, I will get a copy of I'll get a list of all the current residents, and I have them print out a separate list of all the residents who were admitted over the last week, because I try to visit as many of these new people as I can. I introduce myself. I tell them, I ask them, I'm the ombudsman, have you ever heard the term? And almost all people say, never heard it. So I explain that I'm there to help them deal with any issues that may arise while they're a resident in this facility. I walk through, so I go into a unit, and mostly what I do is observe. So in the hallway, I'm looking. Is there, for example, a lot of equipment in the corridor that could make it difficult for a resident to navigate that, or even dangerous for them? Is there a smell of urine or feces? And occasionally that'll happen, and I'm not worried about that, but I would be concerned if it was always in the same location every time I went there. If I happen to be walking down the hall and I see a call light go on, I may just kind of hang back a little bit and see how long it takes for someone on the staff to go in and check on the resident and see what's going on. As I walk through the hallway, again, I'm in the hallway, and I will be looking into, I'll kind of glance into every room along the way where the door is open. And if someone catches my eye or waves to me, I'll go in and visit with them. And as Michael said, this is their home, so even if I know the person, hi, can I come in? Is it okay? Occasionally someone will say, no, get out of here. Okay, that's their choice. But I'll go in and talk with them, find out how things are going. I'll introduce myself. I'll say, you having any problems? No. Is everything okay? How's the food, activities, etc. And I'm fortunate that in the facility that I cover, it's fairly well run, so there aren't a lot of major issues that occur. I'll also visit with anyone who I'm working with on a problem currently, just to get an update or to give an update, or both. And then periodically, I'll check in with people I've worked with in the past, just to make sure things are still going okay. Now, there's one guy, and I introduced Michael to him when he visited with me a few months ago. There's one guy that I always try to visit, because in the year that I've been at the facility, I've never seen this guy without a smile. And I go up to him or if he's in his room, how are you? Everything okay? Everything is great. And he's got this big smile on his face. So it really kind of makes my day. Along the way, I'll also check in with the Director of Nursing and the Director of Social Services. I'll give and get an update on any current problems we're working on. I may raise a new issue, either something that a resident has given me permission to talk about, or something that I've noticed. For example, if there was a strong odor that I noticed in any particular area frequently. And then I also ask these two individuals anything I should know. And occasionally they'll tell me of a problem that they're working on that I wasn't even aware of. Or they may say, you know, would you mind going to visit this certain resident who may be upset, or the family is upset. And so although my job is to just be the resident's advocate, I also work cooperatively with the institution because these people have a hard job to do. I think they also see me. I don't want to use the word ally because that means that we have maybe a stronger connection than we do. But they see me as someone who's, I think, beneficial for them as well, because they know that if I can help them solve a small problem before it blows up into a big problem that gets reported to the Department of Public Health, that's in everyone's best interest. This whole visit takes me about an hour. So it's not a major portion of my time. Any questions on my visit? No? Okay. So I thought I'd talk about a few of the problems that I encounter. I would say the most common one occurs in residents who were admitted over the weekend, Friday, Saturday, or Sunday. And keep in mind, I'm seeing them Monday morning. And these people, first of all, as you would expect, are not happy to be in a facility. And because it was a weekend, things are unsettled, and they're often the resident is concerned about these. I'll ask them what their concerns are, and generally they're scheduling things. Or a problem with their meal, or scheduling the time of medication. And I will tell them that they will be getting a visit that morning from the heads of the various departments, and that they should mention their concerns to these individuals, and that based on my experiences at the facility, it's likely that by midweek all their concerns will have been taken care of. But I tell the resident, I'll stop in again next week, and if there are any outstanding issues, you and I will work together to try and figure it out. And I use the term you and I because although I'm the resident's advocate, I feel strongly that the residents should be in control. They're driving the bus here. You get admitted to any kind of institution, hospital, nursing home, it doesn't matter. You lose a lot of your autonomy. And anything that I can do to help these people stay in control, I think is great for them. Second set of issues that I run into are people are having a problem with a neighbor. Typically it's, for example, a resident will complain because a neighbor who's hard of hearing wakes up in the middle of the night and decides it's a great idea to turn the TV on and blast that volume as loud as it can go, and waking everyone else up in the area. So the resident complains, the staff will come in and ask the person who's playing the TV perhaps if they wouldn't mind turning down the volume, or even if they wouldn't mind turning the TV off because it's the middle of the night. And they'll close the door. And that may work for a day or two, and then the problem reoccurs, and the resident complains again, and this is when eventually I'll hear about it. I may hear about it directly from the resident, but sometimes I'll hear about it from someone else, another resident. Particularly, it'll be the resident council president. This is a person who is a resident, has been elected by the residents to represent them with the administration. So I'll go in and I'll let the person tell me what the problem is. I will ask them what they've done about it, and I will also ask them if they've been offered the opportunity to move. And by the time I get involved, the answer is yes. They've been offered the opportunity to move, but they generally don't want to. So they're happy where they are. And they're looking for me to fix it. And so I tell them, well, this is tough because, as Michael said, this room is your home. The person across the hall, that's their home. And just like when you had your own home before you came here, if you had a neighbor who was playing music late at night, keeping you up, you have every right to go and say, hey, would you mind turning it down after 10 or 11 o'clock? You might want them to move, but you can't demand that they move. The only person who can move is you. And so I say, so this room is your home. No one can tell you to move. That room is his or her home. No one can tell them to move either. And at this point, inevitably, the resident will say, but that's not fair. I'm not the one creating the problem. And I say to them, you're right. It isn't fair, but that's just the way it is. A third set of issues that I've run into a few times are, I would say, cultural differences between staff and residents. Excuse me. Most of the certified nursing assistants, the CNAs, come from the Caribbean. Most of the residents do not. So their gestures, actions, words can be misinterpreted by one or the other, sometimes both. Occasionally, unfortunately, there's a racial bias on one side or the other. And that can obviously be difficult to manage as well. So I'll raise, if the resident gives me permission, I will talk to the nursing staff about this problem. I may, if it's the first time it's being reported, I may just go to the charge nurse on that unit. But if it's something that's already involved the charge nurse, then I'll go to the director of nursing with that. And they're usually pretty good on following up on those things. They'll retrain the staff person and frequently will move them to a different location within the facility. Yes?
As a patient advocate, how are you really received by the administration of the building?
How am I received by the administration? Is that your question?
You just walk in uninvited?
I can go anytime I want between, 8 a.m. and 10 p.m. or something like that?
Usually between 10 a.m. and 8 p.m., we can go in pretty much 7 days a week.
Without an appointment?
That's the beauty of the Ombudsman Program. It is a government-recognized and supported initiative that gives us authority as a certified and trained ombudsman. We're not just volunteers. We are certified by the state as a representative of the people to go in and just to make sure that we're engaging residents to understand what is the quality of care. The nursing home, by regulation, is required to recognize and at least support us in our efforts. Remember I mentioned earlier the role of the contact person, and Don he's talking about his relationship with his contact person, that in his home, it is typically the director of nursing who he's going to, or maybe somebody that she appoints. Other homes, I'm the ombudsman in a different place. The administrator of that home is my contact person that I take things to. They recognize that if we're coming to them, it's with some gravitas, some oomph to the concern, because the resident has given us consent and permission to actually raise that concern. So they know if we're coming to them with something, they need to listen. What they do with it becomes how they're going to process it, but we can then also re-engage with them if we hear that there hasn't been action on something. Hey, what's happened? Oh, we talked about this last week. The resident's still unhappy with. Where are we with the issue? You were going to jump back in. No? Okay. Let's pause for a second.
Sure.
Other questions that you're sitting on at this point? Because we have put a fair amount of content out at you. Did you want to bring something up?
So when you have a resident
That's okay.
when you have a resident that is saying something that, for lack of a better way of saying it, does not raise to the level of a true concern, but may be related more to their perception of things, how is that dealt with?
Well, again, it depends on the nature of the concern. There's a lot of, if we have a lot of leeway in terms of how we deal with problems, at least I hope that's true.
Yeah, you do. Go ahead.
And so if I perceive an issue as being a major concern, I'll do what's called a case report. I open up a case and I start noting the interactions. But on minor issues, I'll give you an example. I went in to see one guy one time, and I introduced myself, and I said, "How are things going?" He said, "Not too bad, but I have this problem with the nurse. I mean, she's just nasty with me." And so I talked with him a little bit, and it sounded like they just didn't get along very well. So I said to him, "Well, and one of his problems was, she comes in to give me my injection, and she stands at the foot of the bed, and he usually sits at the head of the bed working on his iPad." And I said, "Well, maybe the next time she comes in, and instead of expecting her to come to you, why don't you scoot to the middle of the bed and maybe smile and crack a joke or ask her how her day is going?" I didn't do a case report for that. It turned out it didn't work anyway. So, so he gave me permission to talk with the head nurse the next week. And I spoke with her, and she said, "I've spoken with both of them, and this is just a conflict of personalities." The following week, when I went there, I said to him, "So how's things going?" "Things are going great." I said, "So really, things I suggested to you work?" "No." The head nurse came in and moved this nurse to a different location. Problem solved. So I never wrote a case report on that because it was kind of a quickie. Did that answer your question?
So let me share a little bit from as the program director, what I look for in a good ombudsman. You're hearing it already. Don's kindness and compassion, his ability to listen and sometimes read between the lines of what could be said. So there's a sharpness, a keenness for an ombudsman's ability to observe what's going on. There's the ability to be comfortable meeting a variety of types of people, going into a variety of types of rooms, people from all walks of life. That includes the staff. A comfort and a role that they take on as being the spokesman, the advocate, the comfort of being able to raise up someone's voice. Sometimes it can get a little testy between an issue that we're raising and the contact person, because this is what we've done. This is what our policy says. I'm mimicking right now, let's say, the director of nursing's policy or the administrator's policies. And we're saying, but wait a minute. Think about this, whatever the concern is. Let's use the roommate issue, right? The TV, okay? Each of those residents, it's a shared room, each of those residents, we are the ombudsman for both residents. They are sharing a room. And I start to think, and our ombudsman starts to think of this situation through the lens of resident rights. They each have the right to good sleep. They each have the right to watch television. But when one set of issues starts to impact the other, we now have to figure out what could be a resolution to this sticky situation. The other skill that I look for in a good ombudsman is the ability to finesse a set of discussions with a resident, with a family, with the staff. How does that person, the ombudsman, maybe help with problem resolution, thinking on their feet, negotiation? Those are all some of the really important skills, so that and a good ability to listen to what maybe is not being said. Because sometimes we walk into situations and there's a whole history, a whole narrative that we don't have access to. We're being brought into it in that moment in time, and we have to think on our feet and listen on our feet. Like, okay, what's not being said? What am I missing? And so we're listening actively to try to figure out. We're asking good questions, trying to understand what has happened. A concern or an approach that I use around a concern and I ask in the form of a question. What have you already tried to resolve the situation? Because that gives me some important information about that individual's ability to self-advocate, gives me a sense of how long the issue might have been going on. Because Don and I, we go in and, like he said, he goes in for an hour, 2 hours once a week. As the director, I might go in every other week because I'm covering a variety of homes. So we're not there all the time. The other part of being an ombudsman is education and empowerment, helping people be able to hopefully speak up for themselves. And if we can provide some tools and some lenses or frames of reference on how to think about problem resolution, then that's also something that we can offer to the residents living in the building too.
So one other set of problems that I've run into, have had to deal with are family members who are feeling like there's something that needs to change. I've had to deal with I think two over the course of the year, and one came from a daughter, and for a different resident, it was the son. And when we have a hotline, we have a that gets checked twice a day for messages, and so if a message comes in they may not even know who I am, but the person, whether it's the resident or a family member, will say my mom or dad is at this facility and I have the following issues. And so Michael or my other supervisor immediately know who's in charge of that facility. That's me. So they'll get in touch with me. And in each of these two cases, number one, both these adult children said that they were angry and frustrated, and if things didn't change real quick, they were going to file a report, a grievance with the Department of Public Health. They also had a laundry list of issues that were bothering them. So in the first case with the daughter, one of her major issues was that the clothing that was going to be laundered sometimes didn't get back. So the next time I went to the nursing home, to the facility, I introduced myself to the parent. Parent confirmed that, yeah, sometimes a piece of favorite clothing doesn't get back to me. The resident gave me permission to look through clothing, and I noticed that about half the pieces of clothing either didn't have a name or had a faded name, and one piece of clothing had a different resident's name on it. So first, number one, I was able to confirm to myself that there's a problem with the laundry. Second, I was able to validate to the daughter that indeed this is something that should be addressed. But I was also able to give her a suggestion for at least a partial resolution, which was the next time you go visit, bring a Sharpie with you, check every single piece of clothing, and label or relabel anything that's questionable. What I noticed is that when I took care of this one issue with the daughter, her level of anxiety, anger, stress dropped so significantly that she could now be comfortable interacting with the staff on that unit to resolve all the other issues that she had. I didn't have to get involved at all. So that was a real win for me. The last thing, I had another case where it didn't go so well. But in both of these cases, one of the issues for the family members is that they had unrealistic expectations for what their parent was capable of, either physically or mentally. And the nursing home staff were trying to communicate those. And they talked that when I brought it up with the director of nursing, she informed me what they were doing and why they couldn't do some of these other things. It wasn't safe for the staff, wasn't safe for the resident, and they just would not do these things. And I had to agree and tell the adult child that, it is what it is. I want to give you talk about one last interaction I had with a resident recently that really made me feel pretty good and involved very little energy on my part. I went in to introduce myself to a new resident, and as I came into the room, I noticed that the roommate was in bed with the blanket pulled up over her head. Didn't think too much of it. After I talked with this new resident, I'm starting to leave, and I noticed that the roommate is kind of peeking out from underneath the blanket. So I stopped and said, hello, and I asked her if she heard what I had said to her roommate. And I said, so how's things going? And she said, well, things were going great until this morning. And evidently there was some sort of commotion on the unit. Didn't involve her, but it really upset her and caused her great anxiety. So much anxiety, in fact, that she wasn't even able to eat her breakfast. And as she's talking to me, and I just let her talk. And as she's talking to me, I noticed that she pulls the blanket down. She's now sitting up. She seems to be more calm, and she just talked for about 5 minutes. And at the end of that time, I said, so you feeling better now? She said, yeah, I'm feeling a lot better. And I said, well, that's good. I'll check in with you next week just to make sure things are still going okay. And as I start to leave, she starts thanking me profusely for helping her. Now, this is something I had heard during my training, that sometimes just being there makes the difference. And, it reminded me of the old saying of half of the being successful is just showing up. Well, I kind of showed up for this woman. And while I think she would have eventually calmed down on her own, she was very appreciative of the fact that I speeded this process up. And when I saw her the following week, she remembered who I was and started thanking me again all over. It made me feel really good, So I want to close by saying I think if anyone is considering becoming an ombudsman, and Michael may disagree here, but I think the three qualities that you need is, one, a desire to help people; two, a willingness to work cooperatively with the resident's family, and the nursing home; and three, empathy, not just for the resident, but for the resident's family and for the staff, particularly the CNAs, because, they have a tough job physically and emotionally. And you need to take that, I need to take that into account when I'm talking about a problem, whether I'm talking with the resident's family, or with the nursing home administration. That's really all I have.
So we have about 15 minutes left. I want to pause for a minute and just see if there's other questions that you're sitting with that you'd like to ask. I do have one last section of the presentation that I'd like to do, and I need probably about 10 minutes to do that. But what questions do you have for us at this point? Has anyone had to work with an ombudsman in any way, shape, or form in the past? Are you expecting that maybe you might need to, because of the fact that maybe you have a loved one that is going into long-term care, nursing home, rest home, assisted living? Yes? Okay. Do you have a question or anything that you want to bounce around with us? Can I give you the mic?
I'll bring it.
Okay, thanks, Don. It's being recorded, so we do need to make sure your voice carries. Go ahead.
How do you find out if the place where your relative is at, how do you find out if they're under an ombudsman?
Every nursing home
It's not a
is
nursing
required.
home.
Is it a rest home?
It's a long-term care. home?
If it's an assisted living residence, they have their own ombudsman program, yes.
Okay, so it's in the Brighton area.
Okay.
So would that be part of
That wouldn't be part of our program.
No.
But
Boston?
what I can tell you is if you go to mass.gov, it's a website. It's the Commonwealth of Massachusetts website, mass.gov.
I know.
Type in assisted living residence ombudsman. Most likely where you're going to be directed to is Ethos in Jamaica Plain, which is my sister agency in Jamaica Plain that has an ombudsman program for the assisted living industry.
Okay.
If it's an assisted living residence that's south of Boston, around here, for example, all the way down to the Cape, the assisted living ombudsman program for this area is run out of Old Colony Planning Council, which is in Brockton. So the state is covered. It's just it might be a different agency than mine.
It's the Boston area that we were looking into, so.
Okay, so mass.gov, assisted living ombudsman program. So while we're in this concept of a website,
Can I just add?
Yeah, go ahead.
And I don't know whether it's the same at all facilities, but when I became a certified ombudsman, Michael gave me a stack of 8.5 by 11 pamphlets that I gave to the nursing home administration, and they have it hung up at both entrances, at the elevators, and usually at least one other place on every unit. It has my picture on it, my name, our hotline, and just a brief description of the services that we provide. And I think that even if someone couldn't find it, I would imagine just calling the nursing home, wouldn't they be able to give the contact information for the ombudsman there? But one of the other things, when you're looking into a facility, I was amazed that when I went on the Medicare website and looked for the ratings, and you can do that, the home that I'm at had, I think, 1.5 or 2 stars out of 5, which is not very good. And I didn't think that that was appropriate. I think it should have been a lot higher. And when I talked with the director of nursing about this, she said, yeah, that's because it used to be owned by a different company, and they had a lot of problems. And even though we've corrected all of those deficits, we're dinged until our next evaluation. We got to live with that. So kind of keep that in mind as well.
the resource that Don is talking about, there's a resource called Nursing Home Compare. It's a Medicare website, and it's a way that you can compare one nursing home across another. You could even put in several into the search criteria to come up with a way of what I call comparing apples to apples. So that if you want to learn how residence A versus residence B versus residence C compares, you can put in the three names, and if what's important to you is location, the incidence rate of medication errors, how they manage pressure sores, you can put in these different criteria, and now you can compare to see how they would compare one to the other. It can be a very helpful tool if you're searching for a nursing home for someone. Unfortunately, it's only for nursing homes, not assisted living residences and not rest homes, but is a very helpful resource. Nursing Home Compare. You can even Google it because it's a Medicare website.
Yeah, when I went on it, I didn't even realize that. I just went to Medicare.gov and typed in nursing homes,
Yep.
Or nursing home evaluation, something like that, and it popped right up.
There's multiple ways. There's no wrong door into this website. Mass.gov, Medicare.gov. You can find it through different ways. I want to address Don's comment about the poster that we have for every ombudsman in a nursing home. There's a poster. And on that poster is this phone number. So the blue card that you have in your hands, right? 781-930-0200. That phone number rings at our office at South Shore Elder Services. Regardless of the nursing home that you have a loved one, you can call that number if you're looking for the ombudsman for your nursing home or your rest home. Or even if it's a question for an assisted living situation, I could probably pick up the message and direct you to the appropriate place. But know that it's a dedicated private voicemail that comes to my desk or my colleague Marilyn's. We screen every call and then we get back to you. Or we ask Don, based on the call, here's a situation that came through our ombudsman line, please follow up. But that's the phone number, okay?
And if I can just add that I have two supervisors, Michael and another individual, and I can always get in touch with one or the other of them. So particularly when I was starting out, everything was new to me, and whenever I had a question, I would call one of them and say, how should I handle it, or did I handle this appropriately? So, as an ombudsman, I'm never alone. I may be alone in the facility at that moment, but I'm never alone without a support system behind me.
We were talking earlier in terms of the whole group of colleagues that we have that are ombudsmen. Not all of us have come from healthcare. Some of us have. I've been a social worker and have worked in elder care for 30 years. We have other colleagues of ours who are trained, certified ombudsmen that are social workers, nurses, many often retirees. We have a couple of nurse practitioners. We have a couple of physicians. We have a couple of librarians. We have a guy who was the head of facilities for the Boston Sheraton Hotel. So it's a really wide range. We have a couple of people that are still working part-time and they're communications professionals. They're doing marketing and all that. The core thing for everybody are some of the traits and the skills that we talked about earlier. The empathy, the desire to help, and do some problem solving for people. In your packet are a couple of documents that are some of our ombudsman recruitment information and how we make a difference. So that's especially the one where you see the picture of our team. That's the first big 8.5 by 11 document here, right? And you'll see that there's a listing of the cities and towns of all where there are nursing homes and rest homes that we support. It's not a listing of every nursing home or rest home, but it is the communities that where we have homes. Okay, so just so you know the scope of where we have people, where certified ombudsmen are going into the homes in these areas. The next couple of pages are just give you a bit better sense of what the ombudsman does, so that you have an appreciation for that. There is an article in here, the woman with in the red suit. This is a really fine article from AARP Bulletin of a few months ago. It does a nice job of summarizing what an ombudsman is and does. This is a national publication. You will see description in this article based on what we've talked about today, because every state has an ombudsman program in it. AARP did a really fine job with describing that for us. Lastly, I want to leave with you this blue and green document. You heard me talk at the beginning of the presentation about the lens that we think through when we're working on issues. We think in terms of resident rights. What we've talked about is how we do what we do. But I want to leave you with this concept of we try to champion what people, their rights are, and making sure that their rights are being recognized and acknowledged. This is right out of the state law or the federal law for our program and the regulations. So this is a list of at least 8 buckets or categories of resident rights. And then under each bucket are examples of, for example, the right to self-determination. That is a right that a resident has within a nursing home. The right to a dignified existence, quality of life, the right to be fully informed. We do educational sessions like this every so often. Don and I were at a resident council meeting together about 4 or 5 months ago, and we were sharing this kind of material because sometimes even the residents in the building themselves are not up to speed on what their own rights are. We have materials and posters on the wall, but sometimes you just have to walk it through with someone. So I invite you to take a look at these materials in particular, just so that if you have somebody, a loved one, that is in a nursing home, some form of a long-term care facility, these are some of the rights that that person has as they live there. This, like we said earlier, it's their home. But what does that really mean? Take a look at this, and now you'll get a bit more of a flavor for how we're thinking. I want to draw your attention to one area in particular, because it is one of the areas that we do deal with a fair amount, especially me as the director and our assistant director. It's the last bucket. It's the very last part of this document. The right to discharge and transfer. Just glance at those couple of bullets for a second, all right? Get that into your mind. And I want to draw your attention to two things that are inside those bullets. There's a variety of reasons why someone could need to be transferred either to another nursing home, a different setting, back into the community, an assisted living residence, or that they could be discharged to home, maybe with a package of services, because maybe they don't need to stay in the long-term care setting. Sometimes that's resident-driven, that desire, and other times, sometimes the nursing home is pushing someone along, appropriately or not. And sometimes we get involved because a resident or a family member may be calling us and saying, I don't feel it's time yet. I haven't gotten enough rehab. I don't feel strong enough. Or I'm not comfortable with the discharge plan in that, is there going to be enough support for me in my home? Those are real questions that we hope would have been sorted out through an effective discharge planning process. Sometimes discharge planning falls apart. And that's when we often will get involved, because that's going on inside the home, inside the nursing home, has implications for where the person lands later, right? But notice the first two bullets under that section. Any plan that's devised, the resident has the right to appeal that plan. How do they know what they're appealing? Is the second bullet. This is by regulation and by law. A nursing home, a rest home, and yes, an assisted living residence too. They might call it something a little bit different, but they are required to provide a plan, a written plan. That may take several meetings to sort out and several conversations, but that ultimately there's something in writing. In this case, in long-term care, it's called a 30-day notice. It needs to identify where the person is being discharged to or transferred to, the services that could be needed, and the appeal rights. As a consumer of healthcare, every single one of us, when we get into this situation, has a right to have a good plan in place and to appeal it if it's not quite what we need. If you take nothing else away from this presentation, remember that, because that's where it can get sticky. Sometimes situations crop up where maybe there's the desire to have someone move faster than it's needed. This is a way of kind of pumping the brakes. and having there be more thoughtful conversation. As ombudsmen, we are sometimes the brake pumpers to say, slow this down a bit. We need to have more thoughtful conversation. When was the last, these are common questions that I will ask. When was the last care plan meeting, and what was the result of that conversation? And when was the last discharge planning meeting? Those are the two key forums that hopefully will help lay the cards on the table and then be able to re-engage in a helpful, thoughtful plan. It may mean that there's other services that need to be coordinated, etc., but at least know your right to a plan, thoughtfully designed, and the ability to appeal the plan if you don't feel it's solid enough. I want to stop there. Thank you for your attention. And if you have other questions that you didn't have a chance to ask, we're going to linger for a few more minutes afterwards. We're going to probably stop the recording. But if folks, even who are watching this show, this program afterwards, please do pay attention to the phone number that's there for the South Shore Elder Services Ombudsman Program, 781-930-0200. 781-930-0200. Thank you very much.
And I think we can probably leave some of the handouts.
We have extras. We're going to leave
right,
extras.
for people who are listening to this and want to get this information.
Thank you very much.